So, good evening, everyone, and thank you so much for joining us. I'm Rachael Joy, and I'm SheMed's Chief Clinical Officer. So, as many of you will have seen from the email that we sent out, February is actually Heart Health Month. It's really a time that is dedicated to raising awareness around cardiovascular disease and actually how we can prevent it, learning a little bit more about it. So, actually, we have the knowledge to try and help ourselves and help others around us too. It feels particularly important that we're having this conversation in a women's focused space, as heart disease is actually the leading cause of death in women. Coronary heart disease kills twice as many women in the UK as breast cancer, yet there is still a widespread perception that heart disease is mainly a men's condition. That gap in awareness really matters because prevention really starts with understanding what our risk is and understanding a little bit more around cardiovascular disease. So, today we're going to be focusing on women's cardiovascular health and the relationship between our hormones, obesity, metabolic health, and also the long term heart protection that we have. So, we're going to cover four main things. Firstly, how the heart health looks different for women, the connection between our hormones, weight, and cardiovascular risk, what the science actually says about prevention and long term health, and simple, realistic steps that you could take to protect your health in the long term. We're also going to touch on how GLP-1 medications fit into this picture and what the latest research shows about reducing cardiovascular risk with the use of GLP-1s. I want to be really clear from the beginning, this isn't about aesthetics. We really need to understand that obesity is a chronic medical condition. It's biologically regulated and impacted. And when treated properly, we don't just change weight, we change our cardiovascular risk as well. And it's really important that we understand this and the role that GLP-1 medications place in here. So, what this session is about is women and heart disease. So, like we said, heart disease remains the leading cause of death in women, yet women face inequalities in diagnosis and in treatment. There continues to be widespread misconception that heart disease is that man's disease, and the misconception is really dangerous. Actually, the British Heart Foundation has lots of key resources and information and statistics that you can read around women's health. And here's a couple just to mention now. So, women having a heart attack, women often, have a heart attack in their women having a heart attack, often see a delay in seeking medical treatment longer than that of men. And often the reason for this is because their symptoms are not actually recognised by themselves. Women therefore typically arrive at hospital later than men, contributing to the treatment delays in any emergency. And actually, women are 50% more likely than a man to receive the initial wrong diagnosis. That's really, really scary statistic for us all to be aware of. Because of this, women are less likely to receive potentially life-saving treatments in a really timely manner. And it's really important that everything at this stage is timely and fast. Speed is really what we're looking for here. After a heart attack, the British Heart Foundation also states that women are less likely to prescribe medication to prevent that secondary event. And the thing we're really going to talk about now is, what is the heart attack? How do we recognise that between a man and a woman? And what are those differences? So, thing to remember is a heart attack is a medical emergency, and delays in treatment do put lives at risk. So, I would think hopefully many of us are familiar with those classic heart attack presentations. It's often described, and mainly in men, is that sudden central chest pain or pressure, sometimes being told if it spreads down the left arm. And those symptoms absolutely matter, but they're predominantly focused on men. But in a woman, heart attacks often present quite differently. Instead of that severe chest pain, a woman may experience unusual fatigue, so that tiredness, shortness of breath, jaw, neck, or back discomfort, nausea, some kind of indigestion type pain, and that general sense of feeling that something just doesn't feel right. So the symptoms are often more subtle, less dramatic, and they can be really easily missed, both by the person that is experiencing it as you yourself, not aware of what's going on, and also by healthcare professionals, which leads to this misdiagnosis. Um, and I think this is one of the main reasons that actually awareness of what it is, how to recognize those symptoms is really important. Like we've already said, quick treatment is really important here. We also know that women are more likely to develop microvascular disease. This is what affects your smaller vessels, and this can be harder to detect too. Um, I think one of the things then to think about is hormones, and critically, our cardiovascular risk accelerates, so really increases during perimenopause and menopause. And it isn't simply about aging, it's actually about our hormones, and it's a hormone that can make a difference. So, the hormone that we're talking about is estrogen. Estrogen has a protective effect on the heart. It helps control our cholesterol levels, reduce fat buildup in our arteries, maintain healthy blood vessel function, improve insulin sensitivity, and reduce inflammation. Now, as we go through perimenopause and into menopause, our estrogen levels fall. And during that period, our protection actually reduces because our blood vessels become stiffer. Our LDL, which is what we call our bad cholesterol, can rise. Our triglycerides often rise. Our insulin resistance becomes more common, and blood pressure can also rise. We also see that the fat distribution that we experience often goes to our hips, from our hips and thighs into our abdomen, and we get that central abdomen visceral fat, which actually has a bigger impact on our metabolic health. It can produce inflammatory signals that increase cardiovascular risk, increasing our risk of strokes and heart attacks. I think one of the things is to say is that within 5 to 10 years, though, after menopause, the women's cardiovascular risk begins to catch up with men of the same age, and we plateau out. So menopause is not an infinite decline, but it is a real point that we need to think about, and a window of being really proactive in intervention and what we can do to help reduce that risk. Now, it leads us on to obesity. Obesity is one of the strongest modifiable drivers that we have that can help reduce our cardiovascular risk. Not simply because of body weight, but because of how we have that excess adipose tissue, which I was talking about earlier, that's often sitting around our central waist, that can affect our metabolism. This fat really contributes to insulin resistance. It can elevate those blood glucose and HbA1c levels, so our risk of diabetes. It can make us have high triglycerides and increase low density lipoprotein, which is that bad cholesterol, increase our inflammation, and also cause high blood pressure. And together, all of these really do accelerate and contribute to that buildup of plaque in our arteries. One of the things that the British Heart Foundation really emphasises is that maintaining a healthy weight is one of the most effective ways we can reduce our heart and cardiovascular disease risk. So excess weight, especially around our weight, increases our likelihood of arterial plaque formation, raising the risk of heart attack and stroke. So really trying to focus on obesity, reduce down our weight, can really help give us that extra protection as well. So I think this is really what we want to say is obesity is not just focused on excess weight. It's actually thinking about treating obesity to alter our metabolism, alter the chronic inflammation that we may be having, and also that additional stress on our bodies. And it is modifiable. And GLP-1 medication are hand in hand helping with cardiovascular risk and obesity as well. So for many years, obesity treatment was really focused on that short-term dieting. And we now understand that obesity is a chronic biological condition. that improving cardiovascular outcomes requires a really comprehensive support in actually treating that. Large cardiovascular outcome trials have shown that GLP-1 medications do more than reduce weight. Interestingly, there was a trial called the SELECT trial. It did publish some information on some outcomes of adults with overweight or obesity who had established cardiovascular disease, and they experience a significant reduction in any major cardiovascular event when treated with Wegovy, so semaglutide here. So that included reductions in heart attack, stroke risk of around 20%. Importantly, these benefits were actually not just associated with weight loss and actually were completely standalone to that. So regardless of the weight loss that was seen, we still saw that reduction in risk of heart attack and strokes of around 20%. The research was led by Professor John Deanfield at University College London, and it showed that semaglutide, so Wegovy, appeared to improve vascular health independent of that weight loss. And actually, there were some likely mechanisms that were shown here. So improved function, reduced inflammation, lower blood pressure, and improved metabolic stability. I think the one thing also just to add to this is there was actually a write-up regarding this from the British Heart Foundation, which further highlighted that GLP-1 therapies may directly protect blood vessels and the heart. And actually, the data then went on to show that this sustained cardiovascular benefit was shown with ongoing treatment, not with just taking the medication as a kind of short period of time. What then happened was the evidence was really strong enough for them to take to the MHRA. So this is where we have our regulation of our medications in the UK. And they approved semaglutide for reducing serious heart problems in adults who are overweight or obese with established cardiovascular disease. So actually now we have understood and we can use GLP-1 therapies as a cardiometabolic treatment as well as a weight loss tool. Some of the key things that were also highlighted, and there was a study that we called the JAMA study, and it looked at the analysis between stopping tirzepatide, which is Mounjaro, and the impact. And it was really critical of how we think about this long-term care. What the evidence actually suggested is that people that stop taking weight loss medications like GLP-1 therapies such as Mounjaro or Wegovy, they often regain that weight, and with that, they can lose much of that cardiovascular and metabolic benefits that they had actually gained while they were on GLP-1 treatment. So to continue to get that protection, they would have to continue that treatment as well over time. So continuing the medication may be necessary for many people, both for weight loss and maintain weight, and also to see those improvements in heart and metabolic health. It's about treating a chronic condition appropriately over time. It's very similar to with heart blood pressure medication and cholesterol lowering medication or diabetic medication as well. Stopping treatment often leads to the reverse or the progress that we may have seen, and especially if that is done all of a sudden and there's no kind of plan put in place or step down in place where we work with our clinicians. I think really these studies really highlighted, yes, one, the additional benefits of GLP-1 treatments with cardiovascular risk, but also the importance of long-term support and management, and why we shouldn't just be seeing GLP-1 medications as a short-term fix. I think it's really important to say that we've spoken a lot about medications with GLP-1s, but medication is not the only tool that we have. It does work best when it's structured, and that we have those additional support mechanisms in place. So thinking about our lifestyles at this point as well is really important. We often talk about preserving muscle rather than muscle loss during GLP-1 treatment. But actually, there's also other advantages as well with cardiovascular health. So resistance training, it preserves that muscle and improves insulin resistance, its sensitivity. It's really important that we have that adequate protein. Often we talk about this with GLP-1 treatments and what diet we should be focusing on. Many of them overlap. So sleep and stress management, it's really important that we focus on these to improve our cardiovascular resilience. And really thinking about that long-term management as well. Obesity, like we said, is a chronic condition, and they do require structured care, ongoing monitoring, and behavioural support and maintenance over a longer period of time. At SheMed, the care that reflects all of this at SheMed, we try to deliver care, that reflects all of this evidence. We are heart focused, and hopefully we show that through the use of our blood testing as well. We do monitor our HbA1c levels, our lipid profiles as well, both at baseline 6 and 12 months, because we do really believe that the trajectory really does matter. As we know, we support a gradual titration. We really do encourage that muscle preservation and focus on sustainable changes. Weight inclusive care really means we measure by improved health markers, and that we really think about everything holistically rather than just focusing on the scales. It is really important then to think about obesity care as being comprehensive, thinking about our GLP-1 therapy, how we can reduce our cardiovascular risk through exercise, and lifestyle changes as well. So it's not just simply about losing weight. You're improving your insulin sensitivity, you're reducing your inflammation, protecting your blood vessels, and ultimately protecting your heart as well. I think really going to close off and just summarize, because we've given you lots of information. But like we said, heart health does remain that leading cause of death in women, and the risk increases significantly during menopause. Obesity is the strongest modifier driver of cardiovascular disease that we have. And evidence really now does show that comprehensive long-term obesity care, including lifestyle and GLP-1 treatment, if it's appropriate, really can improve not just your metabolic health, but also reduce your cardiovascular risk as well. So really, let's think about prevention and protecting our long-term health, looking at cardiovascular disease. So hopefully it's given you a little bit of a snapshot and insight into cardiovascular disease and heart health. And we will be back soon with some more information and another webinar. So thank you and good night, everyone.